So I know the last video we went through forearm and really kind of talked about the rotation of the elbow, but I want to touch on that again before we go into humerus. So the evaluation of either end of the forearm is important. To evaluate the distal portion of the forearm, the evaluation is the same as detecting rotation in the wrist. So for the AP of the wrist and AP of the distal forearm is the same as is lateral of the wrist and lateral of the distal forearm, with this one possible caveat. That is that on the lateral forearm, the need to slightly supinate the hand is not there. So if the ulnar styloid process is a little bit posterior to the radial styloid process on the lateral of the forearm, that's okay. But everything else should be the same. So shoulder should be at the same height as the elbow. Or really better said, the elbow should be at the same height as the shoulder, as should the wrist. Make sure you've got a 90-degree bend in the elbow, and realize that even though the rotation is the same, the anatomy is going to look different because of the divergence of the central ray. So the fat pads that we're interested in seeing on the lateral of the forearm is pronator fat pad, just like what we saw on the wrist. Supinator fat pad, which should be just anterior to the radial head and the radial tuberosity. And if you've got a radial head fracture, what you'll see in that is an outward bow away from the bone. This is the anterior fat pad, and notice the drawing. I don't know why the drawing didn't have the humerus in the forearm at 90 degrees, but okay. But the anterior fat pad, if it's bowed away from the bone, that's what we call the sail sign. And then the posterior fat pad is generally inside of the olecranon fossa, so you don't see it unless you have a very likely fracture of the distal portion of the humerus. So if you see a fat pad just posterior to the distal portion of the humerus, then there's almost always going to be an accompanying fracture, even if you can't see it. So lateral of forearm should look like this. You're going to have some distortion proximal and distal because of the divergence of the central ray, but that's a pretty good lateral of forearm. So the elbow is usually going to be AP and lateral, but we can have obliques as well. And those are going to be both 45-degree obliques, one medially and one laterally. Your patient, excuse me, your patient for a elbow is going to generally present to you in one of two different ways. If the patient comes in with their elbow straight and they're holding it, not really the elbow itself, but just proximal to the elbow on the humerus, then in my experience and in my practice, every single time I had a patient with an true elbow injury, that they came to me with their arm straight, 100% of the time they had an elbow dislocation. And anytime they had a fracture, they would be coming with their elbow bent 90 degrees and holding the forearm. So evaluate your patient, and before you bend the elbow into 90 degrees for a lateral, take a good look at the AP and make sure that you don't have some sort of dislocation. Likewise, if the patient comes and their arm is already bent 90 degrees, it's a good idea to go ahead and shoot the lateral so that you can evaluate for fractures and evaluate for those fat pads that we talked about before, and take a look and see if perhaps we've got a displacement of the supinator fat pad, or if we see that cell sign, or if you see that posterior fat pad. If the patient comes in with their arm bent, pretty much the only thing that you have to do is elevate it to the same into the same plane as the shoulder, and then if the patient can tolerate it, rotate the thumb skyward so that the wrist is in a lateral position. This is for elbow, granted, but still positioning for an elbow is with the thumb up. So AP of the elbow, remember you're going to have some superimposition on the proximal end. So you're going to see some superimposition of radial head, very minimal. Superimposition of radial head, this is radial tuberosity, so you can follow the cortex of the radius up through the radial tuberosity all the way up into the radial head. So you're going to have some superimposition of radial tuberosity, radial head over the ulna. Keep in mind your anatomy. You've got the capitulum articulates with the radial head, so the trochlea articulates with the olecranon process, and the ulna. That's a really bad picture. It just didn't copy over well. It's good positioning. You can see that we've got almost perfect superimposition of the condyles on the lateral. So again, your positioning is going to be 90-degree bend, everything in the same plane with the thumb pointing straight skyward. If you have a patient that is on a backboard, you can still accomplish these same things. You may have a tendency to want to put the patient's arm across the patient's body, but that's really not the best way to do things. The best way to get a good lateral elbow is to extend the patient's humerus out 90 degrees from the body and have the elbow at 90 degrees from the humerus, and then you can shoot your projection either superior-inferiorly or inferior-superiorly. It doesn't really matter which way you go with it at that point, but try to have your thumb in the right position as well. So again, your positioning and your evaluation on your lateral is very crucial and most difficult portion of this particular test, most complicated portion of this test. So if you don't see that nice round artifact here, where that's your evidence that the condyles are superimposed, or the epicondyles are superimposed, what you'll see is kind of a double halo. So you'll have a round density, and then you'll have another round density just off of that. And that's an indication that you've got a situation where either your hand is too low, your elbow is too high, or your shoulder is too low or too high. So what you're going to do is you're going to look at the relationship of the radial head to the capitulum. So whichever one of those two halos looks like it's articulating with the radial head, that's what you're going to evaluate. So this is posterior, this is anterior, this is distal, and this is proximal. So if you see a double halo where it looks like this one is articulating well with the radial head, but you see another one up here, that's going to be your capitulum or your trochlea. So what that indicates is that this here is up proximal, and that's going to indicate that the shoulder was too low. So if you've got a double halo and you've got good visualization of the capitulum to the radial head, but your other density is down this way, that's going to indicate that your shoulder was too high and your elbow was too low. So that would put your trochlea distal to the capitulum. If the shoulder was too low, that would put the trochlea proximal to the capitulum. If the hand was too low, then what that would do is it would take the radial head and it would project the radial head that way, and the capitulum that would be anterior because we're looking at the anatomy of the humerus. So that would put the capitulum anterior to the trochlea, whereas if the hand was elevated, that would put the capitulum posterior to the trochlea. So your obliques of the elbows just really involve hand placement. With the external oblique, you may have to have the patient kind of lean towards the side of interest in order to get the hand obliqued, and the humeral condyles humeral epicondyles at a 45-degree angle to the image receptor. So both of them are 45 degrees. One's external oblique and one is internal oblique. The hand placement for an internal oblique is just prone. You put the patient's hand flat on the table. Remember, that's pronation, that's not PA. We're not shooting an x-ray of the hand here. That's with the hand pronated. So what we're going to see on those is, and the difference between the two is here. So with the hand externally rotated, what happens is that superimposition between the radial head, the radial tuberosity, and the ulna goes away so that we can see the separation between the two. Some of your hospitals will use a 3-view elbow, and generally speaking, whenever your routine is AP, lateral, and oblique, then this is the oblique that you're going to be shooting. Okay, so it's going to be external oblique so you can see the separation between those structures. Internal oblique puts the radial head and really the radius and the ulna perfectly superimposed, and really the only thing that you're going to see differently is the anterior portion and the anterior most portion of the ulna, and that is the cornoid process. So if a patient has a fracture of the cornoid process on the AP, you can't hardly see it. On the lateral, it's still difficult to see because of the radial head. So the internal oblique is going to show us that. So if you have a patient that you're pretty sure that the patient has a fracture because you've got displacement of the fat pad, and they just don't seem to have a fracture of the radial head, distal humerus, it's altogether possible that they can have a fracture of the cornoid process, and that will be your projection to see that. The humerus comes with a lot of what ifs and alternative positioning just because of the way the extremity is attached to the trunk. So you really want to use a grid because you're getting into anatomy thickness that calls for a grid. Remember that what we use as rule of thumb, if the anatomy is knee size or larger or shoulder size or larger, then you really kind of need to use a grid. And since we're looking at the upper portion of the humerus into the shoulder, we kind of need a grid for this. Because the shoulder is so much thicker than the elbow, we also need to utilize the anode heel effect where possible. If you have a patient who has suspected fracture, don't move them, don't rotate them. Your positioning for humerus is just going to be AP and lateral, and the difference between those two would be your rotation of the humerus. So if you're pretty certain that the patient has a fracture, if they're hesitant to move, or if they're clinically, their history indicates they might have a fracture, older patient fell down and caught themselves on their shoulders or caught themselves on their hands and they don't have any kind of pain or issues in their wrist, then they're going to be suspicious of having a fracture of the proximal humerus, where the distal portion of the humerus slides into the humeral head. It's a compressed fracture. Humerus is tough to phototime. So if you're going to try to phototime a humerus, what I would recommend that you do is pay close attention to where the humerus is in relationship to your center cell. So try to get the center cell as covered up as possible. Even if you do completely cover it up, you're primarily going to be covering it up with soft tissue. So what you might want to do is go ahead and use your density controls, hit it with a +1, maybe a +2, and try to cover your photocells as much as possible. Really, it would be better to set a technique, but if you're going to phototime, go ahead and use +2, use tight collimation. And it is easier to position the patient over the photocell if the patient's upright. But understand anytime the patient has any kind of shoulder injury, there's a lot of positional pain. So going from a recumbent position to upright position can be very, very painful. But if the patient can externally rotate the shoulder, then what we're going to do is we're going to get the patient into a position where the hand would be supinated or in anatomical position if the patient's upright. Make sure the top of the image receptor is above the shoulder. Keep in mind that we're going to have a divergent central ray, so we need enough image receptor above and below, above the shoulder and below the elbow in order to visualize all of the anatomy. And it should look like this. And what we're looking for on the external rotation is the greater tubercle. All right, so the greater tubercle is going to be that bony outcropping of tissue on the lateral side, if you're in anatomical position, on the lateral side of the humerus, proximal humerus. And you can kind of feel that if you put your arm down to your side and internally and externally rotate your arm, you kind of, and if you mash hard enough, you can kind of feel where that greater tubercle is. So the distal portion should look like an AP elbow, except for the divergence of the central ray. Proximal portion, what you should see is greater tubercle in profile. Providing your patient didn't have a suspected fracture, or after imaging the AP, if you notice your patient does not have a fracture, then you can position for your lateral in just using rotation of the humerus. So again, the patient's upright, if at all possible, but keep in mind the patient's positional pain. In both the AP and the lateral, you're going to abduct the humerus. And what that does is it takes the soft tissue of the upper thorax and it keeps it from overlapping the humerus. Very, very important, especially in hypersthenic patients. So abduct the humerus in both cases. For the lateral, you're going to flex the elbow and rotate the humerus until the humeral condyles are perpendicular to the image receptor. So just like in the lateral of the elbow, you want the humeral condyles perpendicular to the image receptor. On the image, they're not going to bear really any resemblance to the lateral of the elbow, though. If the patient's supine, abduct, and then you flex the elbow and place it on the patient's abdomen or behind the small of the back, and it does the same thing. You can position the patient PA. The problem with AP is that if you don't rotate the patient's body, and notice they didn't get you can see this shadow of the breast tissue over the upper arm. If you rotate the patient, you can put the entire arm parallel to the image receptor. But if you don't rotate the patient, you leave the hand across the patient's chest, what you're going to have is foreshortening, because the distal portion of the humerus is going to be away from the image receptor. So you can shoot them AP, but what you really need to do is rotate the patient in order to get that, the entire humerus parallel to the image receptor. If, though, you shoot them PA, it's a little bit easier, but most people shoot AP, so if you're going to shoot them PA rather than AP, then you need to mark your image so that it doesn't confuse the radiologist, make him think he's looking at the opposite shoulder. So the lateral shows the lesser tubercle medially. So if you position like this for the AP, and then you internally rotate and leave the body position identical to this for the lateral, placing the humeral condyles perpendicular to the image receptor, then all you have to really do is follow your thumb. So in external rotation, what you're going to see is you're going to see the greater tubercle out here, and on internal rotation, you're going to see the lesser tubercle in medially. So what do you do if you have fractured position? Your AP, you're going to shoot, and you're not necessarily going to externally rotate the hand and the forearm in order to get it into a true AP position. If you suspect the patient has a fracture, just go ahead and shoot as the patient presents to you, which in a lot of cases is going to be more like lateral, like this right here. So don't do any manipulation or moving of the humerus until you evaluate the image and take a look and see whether or not the patient has any kind of fracture. And then what you're going to have to do is shoot lateral for different portions of the humerus. So for the distal portion of the humerus, you're just going to slide the image receptor as far up under the shoulder as possible. Notice that the humeral condyle is perpendicular to the image receptor here. And then for the upper portion of the humerus, you'll elevate the unaffected arm and shoot a transthoracic. Utilizing a breathing technique, so you're going to use a long exposure time and may require a lowering of the KVP, certainly a lowering of the MA station. Alternatively, what you can do is a Y view. A Y view we're going to talk about in the next section, but a Y view will show you the proximal portion of the humerus, in my opinion, much better than transthoracic. I'm going to be hard pressed to shoot transthoracic on a patient who can move. If the patient is upright and mobile, I'm going to shoot a Y view. If the patient's on a backboard and they just can't move at all, okay, now I might shoot a transthoracic. But if the patient is capable at all, I'm going to shoot a Y view instead of a transthoracic. Number one, it's a much lower radiation exposure to the patient. Number two, it's a much more diagnostic image than transthoracic is. So I'm going to back up a little bit and kind of talk about positioning, and probably the most common mistake that people make in fracture positioning, or any time that they're going to utilize the transthoracic. So if you have a patient that is able to externally rotate the shoulder and get a true AP, but for whatever reason you're not going to be able to get a lateral on them, then this is the problem that we're going to run into. Notice the humeral condyle is parallel to the image receptor. That is true AP. But once the patient puts the arm across the chest, really that's going to put the humeral condyles in an oblique. So if we take a look at this right here, the humeral condyles are really pretty close to parallel to the image receptor. So it's really kind of an AP. So where this positioning fails is in the understanding of what's going on with the humerus on the distal end with the patient's hand across their chest. It's not going to be in true AP, it's not going to be in a true lateral. What you're going to have is a little bit of an oblique, and once you oblique the patient's body, again, you're almost back to an AP. So if we apply that same thing to a transthoracic, we got the humeral condyles, a little bit of an oblique, and if we rotate the patient all the way up, then truly our humeral condyles with the patient's arm across the chest is going to be almost at a true AP projection. So I go to this link to say this: whatever position the humerus is in for this particular view, if the patient, you suspect the patient has a fracture and they come to you with their arm like this, well, that's going to be your AP. All right. So once you turn the patient for a transthoracic, just leave the hand and the arm in that position to shoot your transthoracic. Because if you externally rotate here for the AP, and then you have the patient relax and put their hand across their chest like that, and then you rotate the patient up just a little bit more, essentially what you're going to get is a transthoracic AP. So you don't satisfy that two views 90 degrees from each other criteria that we have to have for fractures.